Today we're going to talk about approach to tachyarrhythmias. This is supposed to be a practical session, so we're going to talk about the techniques that we use to differentiate some types of tachyarrhythmias from other. We're not going to go into any theoretical details about each tachyarrhythmia. So whenever you see an ECG that's fast and abnormal, the first thing you want to know is that it's a narrow complex tachycardia or a wide complex tachycardia. And then you can go from there. So here on the left hand you have a wide complex, and on the right hand you have a narrow complex. So let's start with narrow complex tachycardia. You need to look at two things. So first of all, when we say narrow complex, we mean actual usual complex. I know a lot of our patients are congenital heart disease, and a lot of them are post-surgery. So consequently, a lot of them have right bundle branch block or some sort of bundle branch block. So if the tachycardia ECG, if the tachycardia ECG is similar to the baseline ECG, then that's considered a narrow complex because that's the usual, QRS duration or morphology. So you look at two things, especially if it's an inpatient and you have a chance to look at. So if you're able to look at the trend of the arrhythmia, that will be very helpful. What I mean by trend, how was the onset of it? How was the termination? And what was the heart rate during the tachycardia? What was the trend like? As we talked last time, there's two main mechanisms. There's re-entry and there's automaticity. So a re-entrant circuit, you would have an abrupt, so this is the patient's usual normal heart rate, and then you have an abrupt onset of tachycardia. It's like almost one line, and then the heart rate is fairly fixed while he's in arrhythmia, and then there's an abrupt termination, so like almost one line going down. So that gives the appearance of a box, like on the trend. So this goes with re-entrant arrhythmias. Automaticity is a little bit different. So there's a, for example, multiple. First of all, you have multiple episodes, and they have a gradual onset. So the heart rate goes up gradually until it reaches its peak, and then there's a variability in the heart rate. So here it goes down, and then it goes back up, and then when it terminates gradually. So this is what we call a warm up and a cool down kind of phenomena. So looking at the trend can help you differentiate, because when you take an ECG, it's just a 10-second snapshot of time. So it may look regular, but the trend actually would go with automatic. So if you're able to look at the trend, that will be very helpful. Most of the time you don't have a trend, so you just have the tachycardia ECG. And in that situation, when you have a narrow complex tachycardia, the first question you want to ask yourself, what is the relationship between the P and the QRS? Or from now we're going to call it V and A. Okay? Do you have A is equal to V's, A is more than V's, or V is more than A's? Okay? Because you want to know where this tachycardia is coming from, so this will help you. Okay, so first of all, you need to actually clarify what are the P waves and what are the QRSs. So QRSs are easy. That will be easy. P wave is different. So there's, if you don't see a P wave on the regular ECG, you need to somehow find it. So there's more than one way to do it. First of all, you need to examine all leads. Sometimes you don't see P waves in the limb leads, but you will see them in others, especially V1 and V2, because those are the leads immediately opposite to the right atrium or the atrium. So you may not see P waves here, but you will see them there. So for example, here at lead 2, there's no P waves at all. صح? Okay, but if you look at lead V2, these are the P waves here. So examine every lead closely, and that's why 12 lead is very helpful when you do when you're evaluating a narrow or even a wide complex tachycardia. So examine every lead carefully and look for the P wave. If you still don't see it, and if you have, for example, a patient is post-operative and you have atrial wires, then you can use that. So the way you connect atrial wires, do I have it here? Yeah. So what you want to do is you connect the 4 limb leads the way you usually do. So this will give you a surface ECG. Tamam? And then you connect the wires to 2 other leads that are kind of far apart from them to get a bipolar signal. So we usually choose V1 and V5. And then you set up your printer to print those 3 leads. So when you print it up, you will have in the middle a surface ECG. وبعدين V1, you will have some spikes in there اللي حتكون atrial spike, and V5 is the same. Okay? So the reason you do this is that if you put like if you connected the wires to the lymph leads themselves, you're going to have spikes everywhere. تمام. So sometimes it's difficult to tell مين ال QRS ومين ال spike اللي هي ال atrial signal. So I like doing this because here you have the surface ECG. So the longest one is the QRS. معناته if you go up, this is the QRS, and this other one is the atrial spike. If you didn't have this, you would only see this. So هي الأولى هي ال V والثانية هي ال A ولا أي واحدة. It's hard to differentiate. But if you have a surface ECG to correlate, then you can know which is the atrial spike and which is the QRS. And this is very helpful in post-operative patients, or even patients who have pacemakers, dual chain pacemakers. That will be very helpful if you actually have a chance to interrogate the pacemaker while the patient is having arrhythmia. So this is the way you do it. You put the 4 lymph leads, and then V1 and V5, you attach them to the atrial wires. So this is an example of one. And actually, in some hospitals, they can connect the wires to the telemetry. So you have an like a telemetry strip that has atrial spikes, which is very helpful. So in this patient, so this is what he looked like without the wires. And then when you connect the wire, you see all of these spikes are actually atrial signals. تمام. فهنا it's hard تطب هو هذا ال V ولا is this the V or is it this the V? So you just correlate it to the surface lead. So هنا QRS. So this small one is the V وهذا ال A. So all of these are P waves. Okay. Make sense? شكلكم أعيد. Okay. طيب. So this patient has this rhythm. Let's say tetralogy or Fontan postoperative, and he has this rhythm, okay? Narrow complex. This might be the P wave, or this might be the P wave, أو إنه هذه كلها T wave. There's no P wave here, so I'm not sure إنه هذا sinus ولا لا. Okay? So the way you kind of differentiate, I need to know فين ال P wave. إذا في P wave قبل QRS, معناته it's most likely sinus خاصة إذا كان الرate is acceptable. Okay? If I cannot do it, if I cannot see it, the most appropriate thing to do, I do an atrial wire ECG. تمام. So in this ECG نفس الرhythm اللي في A هو نفسه اللي في B, لكن في B you have spikes اللي هي atrial signal. تمام. اللي هي هذه اللي بالأزرق. Okay. So while this is going on, هذه هي spikes ال P wave. So this is not sinus. You have a lot more P waves going on. في نفس الوقت اللي that you have the narrow QRS tachycardia. Okay, and this is what goes with atrial. It's an atrial tachycardia. بعدين كان يتفكر if it's really that fast, then it's going to be atrial flutter. Okay, this is another patient who has the rhythm in the top. Okay, so this is the baseline surface ECG. في عنده bundle branch block, which is similar to his baseline, فحنسميها usual complex tachycardia. فنطبق عليها all the protocols of narrow complex tachycardia. So the first thing نبغى نشوف فين ال P waves. ما هي واضحة عندنا في ال ECG, so we'll do a wire ECG اللي هي the strip اللي تحت. Okay, فهنا تحت I have this kind of morphology وعندي هذه وعندي هذه. So which one is the A? Which one is the V? I just go to the surface. فهنا في السيرفيس هذه هي الQRS, معناته هذه هي الQRS. This is the QRS, this is the QRS. So معناته إنه this one is the atrial spike. Make sense so far? دكتور محمد عطية. طيب, okay. So once you correlate the QRSs, you know that the other spike is going to be the P wave. So here you have more QRSs than you have V. So the ventricular rate is faster, while the atrial rate is very slow. Okay, so this is a junctional rhythm. But that if in the baseline ECG was not actually sinus. If you don't have atrial wires and you only have the surface lead, sometimes you can do something called Lewis lead ECG. So this is just basically the limb leads, but you position them in the area where they're close to the atrium. At the sternal angle, you put the right atrial lead. At the left right sternal border you put the LA lead, left lower and right lower هذا حتكون في legs. So if they're closer to the atrium, you will capture the P waves more. So this is the normal ECG done. You don't see P waves, but here when you do Lewis leads, you can sometimes see them more clearly. Not a lot of people know how to do that, but just keep in mind it's something that can be helpful for the clinic مثلا or something like that. And sometimes even if you do all of that, it's hard to tell. So if you give adenosine, you can actually clarify the AV relationship. So this will either terminate tachycardia, or we will think about what's the differential diagnosis of that, or it will clarify the relationship for, so here it's hard to tell exactly which is the V, which is the A, and then when we give adenosine, you can see clearly the flutter waves. Okay, so if you don't see where the P waves is, look at all the leads. If it's post-op, do atrial wire ECG. If you're in the clinic or you don't have wires, do Lewis leads. Give adenosine if you don't know, and then we'll kind of figure it out. So once you know what is the relationship between the V's and A's, you can classify them based on the relationship. So if they're equal, or if you have more V's than A's, or if you have more A's than V's. So we should start with the first one. More V's than A's, this is junctional rhythm. Narrow complex, a usual complex tachycardia with more V's than A's, it's junctional. There's no other differential diagnosis, so just memorize that. You don't have to even think of it. It's junctional rhythm, okay? More A's than V's, it's atrial tachycardia, and then you look at the P wave morphology to figure out which type of atrial tachycardia is it. Is it a sawtooth pattern? This is flutter. Is it discrete P waves like this? This is going to be just simple atrial tachycardia. لو نفس المورphology هتكون focal atrial tachycardia. إذا multiple morphologies هتكون multifocal atrial tachycardia. بس كلها under the umbrella of atrial tachycardia. If it's multiple P waves so that they're all so small and there's just a fibrillating baseline with irregular rate, this is going to be atrial fibrillation. Okay. And the more difficult one is when the V equals the A. So then the next thing you want to look at is what is the distance between the ventricle and the atrium. How does the atrial signal come from the ventricle? By which kind of duration? So this is what we call the RP interval. So you have short RP interval, mid RP, and long RP. What you want to do, you kind of measure the distance between the R and R, kind of put a line in the middle. إذا البي wave جات هنا, this is short RP. إذا البي wave في النص, this is mid RP. إذا البي wave in the other half بعد اللاين اللي حطيته, this is long RP. So this is short RP. البي wave جاية هنا, just after the QRS. Mid RP جاية في النص. Long RP, it's very long. لدرجة إنه جاية قبل ال QRS اللي بعده. Okay. So this is what you. This is the same thing we did. So this is what you want to do. هنا عندك ال R to R. حط line في النص. إذا ال P wave هنا, this is short. إذا ال P wave هنا is long. So this differentiation is actually easier, short, mid, long RP from a practical point of view. In the exam, what you will have is just short and long. So what you need to know for the exams, or most of the people when they talk about narrow complex or RP differentiation, they talk about short RP أقل من 70 milliseconds أو أقل من half the R to R. Long RP more than half to R to R. And these for the fellows, they need to memorize it. What is the differentiation of long RP? What's the differentiation of short RP? So short RP, you have orthodromic SVT, the usual accessory pathway SVT, هذا بيكون short RP, and the typical AV nodal reentrant SVT. Okay, long RP is atrial tachycardia, atypical AV nodal reentry, AVNRT, and this is very rare actually in pediatrics, not very common. A specific type of accessory pathway is called PGRT. So PGRT is a long RP tachycardia. Even sinus tachycardia is a form of long RP tachycardia. And زيه زي الاتريال نفس الشيء. So what do you think of this one? Rehan. Short RP. Short RP. Oh, mid RP. If you want to go with that differentiation, but yes, it is short RP. How about this? Let's start the analysis from the beginning. So say narrow, wide, وبعد كده إيش ال A وال V, and then دقيقة وش ده?
This is a narrow complex tachycardia. The Q. The atrial equal to the ventricle. So
Okay. So look everywhere just to make sure you're not being fooled, because yes, here it looks A equals V. But just make sure from all the leads so that you're absolutely sure that A equals V. Does anyone else see anything else? Or you all agree that A equals V?
Which one the B?
I think the 2B is more than V. A more than V.
A more than V, right, here.
Also PV1.
Hannah.
Yes.
So actually these are multiple P waves. And this can happen in atrial tachycardia, لأنه زي ما قلنا it has a warm up and cool down, so sometimes you would have a speeding up of the atrial rate and then it will go down فحيصير 1 to 1. So A more than V, so this is
different morphology.
yeah. So just say atrial tachycardia وبعد كده just يعني see what kind of atrial tachycardia you have. Okay. Rajab. So I'll give you some context. This is a 90-month-old who had tetralogy of Fallot, and you recall because the heart rate is persistently around 190 to 200. And he's not hypovolemic, he's not on any inotropes, his function is normal, he doesn't have fever. There's no reason for him to have tachycardia.
Yeah, one of them on the bench.
Right, so this is his baseline. Yeah, excellent, تمام. So we don't call this narrow complex, نسميها usual complex, but we will apply the same protocol حق narrow complex, تمام.
I think in the short RP. مش شايف البي كويس بصراحة.
Short RP, so this is RR.
Yeah.
If you put a line here, the P waves comes here.
Yes, long RP.
Long RP. طيب.
long RP تحت.
ساعتها تشوف ال P wave morphology. إذا ال P wave morphology is similar to sinus, this is sinus. If the P wave morphology is different, then this is atrial tachycardia, and then you need to kind of differentiate which type of atrial tachycardia. So what do you think?
tachycardia أو الBGRT.
Yeah. Okay, so what do you think about the morphology? So what's the normal P wave morphology? A sinus morphology. What is this sinus P wave morphology?
نفس البي تساوي البي ويف نفسها.
P wave morphology. What does the P wave look like in sinus rhythm?
الامبليتيود بتاعتها ما يبقاش اكتر من
Morphology. Not voltage. Morphology. Morphology meaning its axis مثلا. What's the axis like?
تكون بوزيتيف في AFF ونيجاتيف في AVR.
Yeah, so usually positive in 1, 2, and 3 in AVF, negative in AVR, and usually equivocal or isoelectric in AVL. تمام? So this actually looks like that. One, positive, 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 negative in AVR. It's positive in AVL, so that's abnormal a little bit, while AVF is positive. So this is very similar to sinus. But the point of bringing this question is showing you how trend can be very helpful. So this is the patient baseline heart rate, kind of around 130, 140, which is normal for a 9-month-old. And then it jumped up to this kind of tachycardia, and it stayed the same. So if you look just at the ECG, you may say that it's normal, but looking at the trend, you find that this is not normal. And sometimes if you have a focus just near the sinus node, it can give you a P wave morphology similar to the sinus node. But if you just look at the ECG, you'll say it's normal. But looking at the heart rate trend tells you that it's not actually normal. So if I didn't bring you this, then I would accept if you would say the sinus. Then maybe I would say sinus as well. But the trend is the one that points you that there's something wrong. So if it's available, it's better to look at both. Especially if you have a patient who has a heart rate of 200 without a reason, and he's not hypovolemic, he's not febrile, he's not on inotropes, so that would be very helpful to look at the trend. Okay.
What's the diagnosis in cardiology?
So this was atrial tachycardia, ectopic atrial tachycardia. And it was interesting because once we started esmolol, heart rate went down, and AVL became isoelectric. This was the only change that we saw in the ECG. So, yeah. So this is not a straightforward case, but I'm just bringing it to highlight the importance of the trend, looking at the trend. Okay, Dr. Amjad.
This is look like neurocomplex QRS.
Okay, tamam. So once you have a narrow complex, you want to say, is it A more than V, V more than A, or equal?
A is more than B.
Tamam. And then, so what is it?
It's look like
So when it's A more than V, what kind of tachycardia? Tachycardia, tamam. And then you look at the atrial morphology and you determine what type of atrial tachycardia. So here it's hard to tell, but look here when you have more interval, so you can actually see the P waves more clearly. What do you think?
look like atrial flutter.
Yes, yeah, you have a sawtooth pattern, so this is atrial flutter. Tamam. This one, جاسر. كل واحد على مقامه يعني.
artery irregular.
Okay.
Narrow complex.
تمام. A more than V, V more than A, or equal?
في PCCE فيها نص
طيب هذا خليه على جنب شوية البي بي سي، أوكي؟
بس ال A more than V.
Okay, تمام. So A more than V is what? It is atrial tachycardia. طيب.
معاها أشبه كمان يعني فيها شوية معاها
Yes, yeah. So you have, before I say that, the P waves are not actually the same morphology. So this is downward notched, this is downward regular, this is downward. So there's probably 3 different morphologies. So that's multifocal atrial tachycardia. And then usually you try to kind of give one diagnosis for the ECG. There's rarely you have multiple types of arrhythmia at the same time. So if you have multifocal atrial tachycardia in some wide QRS complexes, then they're most likely aberrant QRSs. This is an ectopic P wave that does not conduct. This one conducts normally. This one doesn't conduct. This one doesn't. This one conducts normally. This one conducts with aberrancy. So here, these are all atrial ectopics. And then you have one sinus beat here. And then another P wave conducts with aberrancy. Same thing here. And then you have a faster run. And then it goes back to PACs. Okay? So if you see something that's disorganized like that, just take one strip and kind of focus on it. And looking at all leads helps. So even if this lead is not very helpful, look at lead V1. It's very helpful. There's very clear P waves. So V1 and V2 is very helpful when you look at P wave morphology. Okay.
This is another complex tachycardia. A equal to the B.
تمام.
So we need to look for the AB is long or short.
Okay.
It's long.
Right.
Okay.
Differential diagnosis.
Either typically ABNRT or BGRT.
Okay. هنرجع للديفرنشال diagnosis.
Orthodromic is BT, BGRT, or atypical ABNRT, or atrial tachycardia.
Yeah, so either atrial tachycardia, atypical ABNRT, or no, this is rare, so you don't put that diagnosis in children unless there's no other differential. Orthodromic SVT with slowly conducting history pathway, here PGRT. Okay, so sinus, if the rate is acceptable. So which one is this?
I think PGRT.
Okay, so usually PGRT in atypical AVNRT, it's easy to tell because they have negative P wave in lead 2, always. Okay, so if it's not negative, then it's not PGRT and it's not and it's not PGRT. This is kind of an easy way to tell. So this is just atrial tachycardia, regular, depending on the P wave morphology. This one, أحمد. أنا نسيت أرجع كتاب بس نبدأ أحمد.
complex.
Uh-huh.
I think it will be.
Okay.
Short or medium.
Well, so the P wave is actually, sorry, the P wave is this one. So if we put a line between, yeah, it's short. Okay. Differential diagnosis.
We command UVR or SVT.
وtypical AV and RT. اوكي درجة أظن هذا آخر واحدة. أي تفضل. So this is the tachycardia I want you to comment on, and then once you finish that, tell me what happens when we give adenosine.
Okay, برضه non complex tachycardia.
Okay. So all your analysis is based on this section, تمام? Not this section. Long RP.
لونج ار بي بتعتمد على تاكيكارديا او بي جي ار تي.
Okay.
احنا في اي دي بي.
Or
نشوف في ناحيه
atrial tachycardia, AV and RT أو
اتر تاكيكارديا او بي جي ار تي.
أو
اس اف تي.
atypical AV and RT.
او الاتيبيكال اي ار تي اللي هي ريال.
اللي هي ريال تمام. Yeah. So what happens when you give adenosine? So just based on this ECG, you actually cannot differentiate. ممكن تكون أي واحدة من الثلاثة هذه.
المطلوب البي slow heart rate with المطلوب البي مع اللي كيو ار اس.
Okay, and what did so how is the rhythm after the adenosine? You sure?
It seemed to be like converted to a normal rhythm.
هسه مطلوب بي ويفز وبعدين كيو ار اس يعني.
Where's the multiple?
slow الريتم وبعد كده رجع تاني.
Yeah, so the rates slowed down. وما رجع تاني. Here it's still normal. P waves becomes upright. بعد ما كانت negative becomes upright and it stays upright. So after adenosine it converts back to sinus. If you see the P wave morphology and the rest is actually normal. Upright V1 biphasic and then it goes back uprightly. Vagal precordial leads and the right-sided ones and the lead too. So does this help you? Does it differentiate which واحد من الثلاثة?
Normal differential diagnosis.
Okay, so what does this exclude?
exclude الاتريال تاكيكارديا.
تمام, right.
تمام يبقى معايا البي جي ار تي ومعايا الاس بي تي والاتيبيكال اي بي ار تي.
Yes, exactly. You usually differentiate them by age, actually more. PGRT comes in younger children, while atypical AV and RT in older children. So if this was atrial tachycardia, what would you expect the response to be? Why did you exclude it?
atrial tachycardia لو احنا ادينا ادينيسين جاست لو حسن السوفيج هترجع تاني atrial tachycardia.
Yes, تمام. So it will slow down the rate, but the P wave morphology will stay the same.
Yes.
Okay. فاهمين ايش اللي قاله دكتور رجب؟ ولا نرجع نعيد ثاني؟ Okay. So because this is a re-entrant circuit والAV node جزء منها. If you terminate the AV node, you will stop the circuit. فخلاص الرhythm will stop and it will go back to sinus. If this was a focus in the lower atrium that's just giving you ectopic kind of beats, and you give adenosine, you will slow down the rate, but you will not affect the focus, so the focus will keep on giving you beats. So you will see the rate slows down, but the P wave doesn't really change much. Okay, so that was narrow-complex tachycardia, usual complex tachycardia. Is it clear? Any questions on it?
دكتور معلش التيبيكال ولا اتيبيكال اذا نعطي كيف نقدر نفرق بينهم بالبي سي جي؟
بالRP interval. محمد sorry. بالRP interval. So short RP interval is typical. Long RP interval is atypical. No, there's no other way. Okay, so wide complex tachycardia. The differential diagnosis is commonly two things: either SVT with aberrancy or VT, and you all know that. Other differential diagnosis is SVT with drug or electrolyte-induced QT widening, especially in patients taking high doses of antiarrhythmics. So, for example, a patient coming in with flecainide poisoning or something like that will be, or a patient who has electrolyte abnormalities, calcium, especially in potassium, they might have those. Rarely, it could be related to tachycardia occurring in the context of pre-excitation. But pre-excitation, you will have wide-ish QRS complex, and if it's tachycardia occurring on top of that, then you may have a pre-excited tachycardia, and we will talk about that. So mainly you want to differentiate between the common ones, SVT with aberrancy or VT. One of the main left anterior fascicle and left posterior fascicle, this will give you an axis deviation. So if you have right bundle with left anterior hemiblock, iconic left axis deviation, and that's the way I memorize it. So L left axis deviation, left anterior hemiblock, LA. Right bundle branch block with right posterior هتكون right axis deviation. If you have a bifascicular block with first degree AV block, it means all of the three are actually blocked by the trifascicular block. So if you're following a patient who, example, can عنده complete heart block وهي recovers with this, it means actually he has a higher risk إنه يكون عنده. إذا جاك مريض with myocarditis بدأ بnormal sinus rhythm بعدين بدأ يصير عنده right bundle branch block بعدين بدأ يصير عنده first degree AV block, you know that he's having progressive conduction system disease. So you need to be very aware of how to monitor this patient. Okay, so let's practice what we just said about bundle, left and right bundle branch block, what types of it. So, وجدان إيش رأيك؟
This is right bundle branch block.
تمام. Anything else? This patient has, for example, structure normal heart.
That's the
تمام. So which one of the blocks is that?
bifascicular.
Bifascicular, which type?
So right bundle, left anterior.
Yeah. Oh, okay. Okay, this one. رجب.
برضه ده الشكل الراكب عند البرناش بلوك والاكسس بتاع رايت اكسس ديفيشن هي رايت باند البرناش بلوك ومعها رايت انتيريور.
Right anterior. And you can actually see the cause of this, and he has SC segment elevation, so it's related to ischemia, that's why he has it. Okay, Rehan.
Right bundle branch. With left axis deviation.
تمام.
Bifascicular.
Okay.
Left anterior.
Yeah, left axis, left anterior hemiblock, right? Anything else? The PR interval, okay? The PR interval?
First degree.
Yeah.
First degree heart block.
So what do we call this? Trifascicular block. Okay, so how we differentiate? How do we know? And this wide QRS is actually ventricular kind of rhythm. So first of all, the wider the QRS, the less likely إنه هذا is just aberrancy. Aberrancy gives you wide QRS, but it wouldn't be very, very wide. And the age also can help you. So most of the wide complex tachycardia in adult and also in adolescents are VT. Most of the wide complex in pediatrics in young age is actually supraventricular with aberrancy. Hemodynamics, a lot of people say ventricular would be sick, supraventricular he would be well, but that actually does not help you. You can have a supraventricular tachycardia with aberrancy that's actually very hemodynamically depressing and he would be compromised. And you can have VT that's perfectly stable. So hemodynamics don't really help you a lot in that. History is very helpful. So if you know that this patient has a previous tetralogy repair or had VSD cath closure, it means that his baseline ECG is probably has a bundle branch block, and this is probably SVT with aberrancy. If you know the baseline ECG, that actually would be very much helpful. So if he has a bundle branch block and it's a similar morphology to your tachycardia, then this is SVT with aberrancy. If it's different, then it's probably different. Or if there's pre-excitation. A northwest axis meaning negative in 1 in AVF. If you have a structure in normal heart, this is always VT. تمام. If you have a congenital heart disease, it does not really help you much لأنه ممكن البيزلاين حقه يكون northwest axis. But if you have a structured heart disease and northwest axis, this is most likely VT. If you have AV dissociation or signs of AV dissociation, so either you actually see P waves that are marching through the QRSs وما هي جزء من it's not actually related فما هي after it ولا immediately before it. This is pathognomonic for VT, so you can say 100% this is VT, not most likely this is VT. And actually, a lot of people say that actually you don't see that a lot, but if you print out a long enough rhythm, even if you print out more and more strips, you can see that up to 50% of the time. Two other more features of AV dissociation, if you have capture or fusion beat. So if you have كلها wide وفي النص جاك شيء narrow, this is VT. Or not exactly narrow, but narrower than the wide complex. So this is the patient narrow in normal sinus rhythm. This is the patient's VT, and this is what we call a fusion beat. So it's between this morphology and this morphology. It's not exactly narrow, but it's narrower than this, the fusion beat. So if you see AV dissociation, fusion beat, capture beat, there is 100% VT. وهذا الشيء الوحيد that tells you in 100% VT. باقي features maybe and maybe not. Precordial concordance. So if the QRS axis is the same in all the leads, this goes with VT. فلو كله positive أو كله negative, this goes with VT. Usually أنت بتشوف right أو left bundle branch block فحيكون مثلا positive في V1, negative in V6. بس لو كلها نفس direction, this is most likely VT. So هذه الأشياء, if you actually do it all, you will reach the diagnosis up to 60% of the time. If you look at the baseline ECG, know the prior history, look at the axis, هل هو northwest ولا لا. Look for AV dissociation, fusion beat, capture beats, and precordial concordance, you will reach the diagnosis most of the time. غير كذا, you kind of need to go through what, sometimes you need to kind of look it up because I don't expect you to know that. What you're actually looking for, you're looking for atypical right and left bundle branch block. So if it's atypical, or if you have no concordance, معناته you have some R complexes and some S. So if you measure from R to S more than 100 milliseconds, this is most likely VT. If you have atypical right bundle or atypical left bundle, and I'm not going to go into details of that because you can kind of read it, you don't need to know all of that. But anyway, if it's not a typical M-shaped pattern for right bundle or the typical left bundle branch block, then this usually goes with VT وهذه الكرايتيريا that you would see. It's okay, I'm going to skip that. One of the easiest algorithms that recently been developed is just look at AVR. AVR positive, most likely VT. AVR negative, doesn't really help you. ممكن يكون VT, ممكن يكون SVT. But AVR is really, really helpful. Okay, so this is how you differentiate them. Let's practice. Abdulhamid, what do you think?
And then a wider complex tachycardia.
Okay.
Okay. It's left bundle branch.
Okay.
Okay. Precordial concordance.
Is it? Negative V6, positive V1.
V1,
so
yeah.
no.
Okay.
Yeah.
So northwest.
So first thing, look at AVR, look at the axis. إذا ما ساعدتك روح شوف الأشياء الثانية. Okay. So what's AVR? Positive. What's the axis?
Northwest.
Northwest. So just these two helps you say that this is most likely VT, and then you can go ahead and kind of test it. Look at the bundle branch block. Is it typical? Give adenosine and see what you see, and then you can go ahead from there. This one. أنا بختار. طيب جاسر.
طيب يبقى complex tachycardia. Axis. It's normal axis.
Yeah.
الEVR negative, الR wave negative في الEVR. بس يعني. V1 right bundle branch. دي تمشي أكثر مع صورة من فكرة tachycardia.
Exactly. وكمان اللي يساعدك في الشيء هذا إنه the QRS is not very wide. QRS is not يعني it is wide, but it's not incredibly wide. And maybe it's just 100 or something. So it's not. So that would be. So this is most likely SVT with aberrancy, and then you can give adenosine, or kind of test it. Okay. ريحان سويتي وايد كومبلكس ما سويتي ريحان.
Right complex. Left bundle branch.
Right.
قلنا الأكسس AVR negative. وال1 AVF positive. Right. Normal axis. So most likely SVT.
Okay. وفي أي evidence of AV dissociation? Capture beat, fusion beat, أي شيء زي كذا. No. So most likely SVT with aberrancy. وهذه كانت AVNRT with left bundle branch. Okay, this one. دكتور رجب.
برضه وايد كويس AVR بوزيتيف بيتا.
Okay, لا كمل. فتقول most likely بس يعني talk about the other criteria يعني. Okay, AVR positive صح. There's a paper about AVR algorithm, and they just look at AVR, and it's helpful يعني. بس يعني برضه just for practice كمل يعني.
وايد كومبلكس تاكارديا.
Yeah.
واحدة شكل رايت باندل برانش بلوك. الواحد واف اف.
أنا كمل.
واحد نيجاتيف واحد اكستريم اكسس يعني
Northwest axis. Okay, so this is also goes with the VT. Anything else?
وكونكوردنس كمان.
Actually, no. It's discordant. Huh? Positive V1, negative V6, so it's discordant. No. هذه ما تساعدك. So if you have concordance, this is probably VT. If you don't have it, it could be VT, it could be SVT. It doesn't help you much. Okay, so for the ECG, you need to look very closely at the beat. So what is this? A deflection here, a T wave, and this one, and this one, this one.
Dissociation.
Yeah, are they P waves? So this is AV dissociation. Okay, so yes, I agree, VT. Okay, تمام. Okay, دكتور أحمد تمام. This might help you actually. This is his normal ECG. So there's no right bundle branch, there's no bundle branch block, and there's no clear excitation. Go ahead. It's not. The main force here is positive, so it's positive AVF negative 1. Left axis.
أنا فاهم الشايف. الشايف. دي نفس.
This one. Here. Okay. Any signs of AV dissociation? Because this is what would confirm for you. You sure? Look. AV dissociation, you need to look very carefully, and sometimes زي ما قلنا you need to take more and more strips فتطبع أكثر من ECGs just to look for it. So actually, this is a P wave هنا, part of it, but clearly هنا, this is a P wave, and there's another one here. فمرة قبل الكيو ار اس بصورة واضحة، مرة داخلة في الكيو ار اس قليلا، مرة داخلة فيه أكثر. So this is AV dissociation. So this is VT actually. So what actually tells you in a VT. AV dissociation 100% tells you it's VT, and then AVR is positive, so that will also help you. Okay, this one. من دكتور جابح.
طيب welcome to Maghrabi when the AVR is positive. Right axis deviations.
Right axis deviation? Left axis, okay. most likely بالضبط. Yeah, and something else that will tell you the concordance. V1, V2, V3 كله negative. Okay, so كله negative. This is negative concordance, so this is most likely VT. كلام جد. ايش رايك؟
Wide complex tachycardia, right bundle branch block. V1 is M shape.
V1, yeah, تمام.
V wave looks completely dissociated.
Okay.
I think this is beta.
Why? It is VTAC, but why? No, I'm good. So AVR is what? Positive or negative?
That was the one on AVF.
Yeah, AVR. AVR.
AVR positive.
AVR positive, so this goes more with VT. Tamam. Axis here doesn't really help you. It's negative axis. There is, what is this? هذه البيت, what do you call it? So all of this is wide, and then here it becomes narrow. صح? هنا يمكن أوضح. Wide, and then narrow. So what do you call that? Anyone? Capture beat. So once you see a capture beat or a fusion beat, this is definitely VT. Actually, one of the signs also in a AV dissociation, and you can actually see the P waves. So they're marching through with a fixed kind of rate while we have a wide complex tachycardia. So.
لو انت مش شايف البي ويف خالص يعني لو مش قادر تقول ان في ديسوسيشن ولا مفيش بص على البي ويف لو هم مش in the same level يبقى ده
بالضبط because if you have a P wave in the middle هذا حترفع لك أو توطي لك ال T waves. So yeah, exactly. This one.
White cloud is good. Tachycardia.
Yeah.
There's a dissociation.
Okay, صح. هنا في P waves, هنا في P waves, هنا في P wave, I think it's a bit more helpful than it's.
This is northwest.
Okay, so axis is helpful if it's monomorphic VT. So لو نفس المورفولوجي حتعرف ايش الاكسس لانه في يعني شو اسمه عندك bleed one either positive or negative and AVF either positive or negative. If you have multiple morphologies, you cannot comment on axis because so it's multifocal. فايش قصدك bidirectional?
Bidirectional QRS.
Yeah, what does that mean? صح, but what does it mean?
It's right on the branch also.
Okay, but what does bidirectional mean?
It's usually coming, the differential, the CBVT comes.
Yeah, I don't want differential. No, what does it mean if you have bidirectional VT? Bidirectional means you have two directions. So you have two alternating axes. But QRS once positive or once negative. So هنا positive, negative, positive, negative, positive, and negative. Oh, sorry. So هذه is a bidirectional VT وهذا لها specific kind of differential diagnosis. What is it?
CBVT.
Yeah.
Also Anderson Tawil.
Anderson Tawil.
Anderson Tawil, and the third one is the VT, normal VT.
No. VT due to ischemia ممكن يكون bidirectional. And the digoxin toxicity is bidirectional. هذه أربع differential diagnosis. Last one. Who wants to do this one?
شايف هنعمل كومبلكس شايف البي ويف واضحة في واحد
كله نارو؟
لا مش كله لا
اوكي
في تحت وايت كومبلكس
تمام
الاكسس بتاعها ده نورمال اكسس نورمال اكسس بيبقى نيجاتيف صعب تكمل شوية وبعدين في الاثنين وايت كومبلكس وبعدين في اثنين نارو كومبلكس يعني كأنها كابشر بيت.
yeah ايوه وفي اي في dissociation هنا لانه هنا تبدا P wave وبعد كده تجي QRS ف this is not a normal this wave does not conduct to this one ف it's not but this is not tachycardia but it's a rhythm fusion بالضبط. So what do you call this? Wide complex rhythm similar to the normal baseline rate. لا good. Multifocal?
لا يعني بريفنتيكولار تاكيكارديا BVCs.
Okay, so PVCs by definition it's premature ventricular contraction. Premature means it comes early. These do not come early. They're just regular slow wide complex. في rate يشبه rate of the sinus rhythm. تمام؟ فنسميها accelerated atrioventricular rhythm. Okay. فلما تلاقي الريت within احنا نسميها يعني within 20% of the sinus rate this is accelerated ventricular rhythm. And this is benign, yeah, usually. Not all the time, but usually. Okay. Okay, so just to summarize, if you approach a patient with
عايز مور ديتيلز عن الهيليوفنتريكال تاك. انا
sorry
الهيليوفنتريكال تاك ريزم مش فاهم الميكانيزم بتاعته.
Atrioventricular rhythm. So we all have backup pacemakers for the heart. So if the sinus node fails, the AV node or low atrial rhythm will kind of pick up. If that fails, the junctional beats will take over as a pacemaker. If the AV node fails, the ventricle itself, الميوكارديوم نفسه حق الventricle, has its own atrioventricular rhythm.
عشان يحصل الكلام ده.
كيف؟
نبقى براديكارديا اصلا.
لا ما هو دائما. So if the normal atrioventricular rhythm يعني if all the pacemakers of the heart fail, the normal atrioventricular rhythm between 30 to 40 beats per minute. If you have an accelerated atrioventricular rhythm, it can sometimes override the sinus node. تمام؟ فهو هذا الaccelerated atrioventricular. لكن because it's not very fast, it's usually benign. Rarely they become symptomatic because of loss of AV synchrony. But this is very rarely that will happen. But most of the time it's benign. يعني. زي المريض اللي شفناه في NICU اللي كان عنده. Okay, so first of all, make sure the patient is stable. If he's unstable, don't bother with everything we talked about. Just shock him and then figure out what that rhythm was. If it's stable, always get a 12-lead ECG. Don't base any diagnosis based on monitor rhythm ولا rhythm على strip. Always get a 12-lead ECG. And then if it's narrow QRS, try to determine what is the AV, which is the A wave, which is the V wave, or P wave or QRS, and then what is the relationship, A more than V, V more than A, or they're equal. If they're equal, what is the RP interval? And then you'll get your differential diagnosis. If it's wide QRS, you want to differentiate between SVT with aberrancy and VT. Okay, any questions? Thanks,
Thank you very much.